Mask wearing is unfortunately controversial. Getting people to mask is often difficult. The results of a study on community mask wearing and its effects on the spread of COVID-19 have just been made available to the public. And not only do the data support mask wearing, they provide some direction on how we might increase that behavior. And that's the topic of this week's Healthcare Triage. To the research. This study, made available as a working paper in August of 2021, was an 8-week cluster randomized controlled trial of 600 villages in Bangladesh. Intervention groups were given masks and information on the importance of masking, text and in-person reminders to mask, and mask role modeling by community leaders. Mask distribution and promotion occurred once at individual households and at regular points after that in public spaces. Promotion included a video shown to each household on why, how, and when to wear a mask. In public spaces, this information was discussed with non-mask wearers to encourage them to use a mask. Control villages received no intervention. Prevalence of mask wearing and physical distancing were directly observed at major gathering places such as mosques and tea stalls, as well as main entrance roads to villages. COVID-19 symptoms were surveyed at 5 and 9-week follow-ups, and blood was collected from symptomatic individuals to confirm infection. In villages receiving the intervention, mask usage approximately tripled to 42.3% from the 13.3% observed in control villages. Increases were larger in villages with baseline mask wearing rates that were below the median rate when compared to villages with baseline rates above the median. Physical distancing was approximately 5 percentage points higher in the intervention villages at 29.2% compared to 24.1% in the control villages. One major thing this tells us is that increasing protective behaviors like mask wearing does not decrease other protective behaviors like distancing. In other words, people aren't engaging in riskier distancing practices due to feelings of increased safety thanks to mask wearing. The tripling of mask usage seen in intervention villages was sustained for 2 weeks after the intervention, and though the impact of the intervention lessened considerably after 5 months, mask usage remained 10 percentage points higher compared to control villages. Specific measures of the intervention were analyzed and did not appear to impact mask-wearing behaviors. These included text message reminders, monetary incentives for villages, and commitment signals such as signs indicating mask-wearing households. The authors also reported no significant effect of self-protection versus altruistic text message reminders, nor a specific effect of twice-weekly texting or verbal commitments. There did appear to be a small effect of mask color, with some mask colors enjoying more adoption than others. Which measures then are responsible for the increased uptake in mask wearing? Beyond mask distribution and role modeling, incorporating mask promotion seems to be a critical component. Data from 2 initial pilot studies, one with mask promotion and one without, suggest that the inclusion of explicit mask promotion increases mask usage by 28.4 percentage points compared to only 10.9 percentage points without it. So we know the intervention was effective increasing mask wearing, which is great. Now we want to know, what does that mean for the spread of COVID-19? In the intervention villages, there was an 11.9% reduction in the prevalence of COVID-19 symptoms. In addition, symptomatic seroprevalence, meaning the number of people reporting symptoms who also had antibodies for SARS-CoV-2 in their blood, in other words, a confirmed infection, was reduced by 9.3%. While that number doesn't reflect the whole picture because only 40% of symptomatic individuals consented to have their blood taken, it's still a pretty encouraging outcome. Keep in mind that this reduction was seen with only about 42% of people wearing masks. And I also grant you that these are relative risk reductions, but you gotta understand that the starting absolute risks were also very small to begin with, so there's never gonna be a huge change in absolute risk. The study also examined differences between cloth and surgical masks in reducing symptoms of COVID-19, finding symptom reduction in villages using both types of masks, but a larger reduction in villages using the surgical masks. When looking at symptomatic seroprevalence, the effect was no longer seen with cloth masks, but the effect of surgical mask remains. As with all studies, there are some limitations here. Given the nature of the study, it wasn't possible to blind staff or participants, meaning that mask-wearing behavior could have changed based on factors like knowing that mask usage was being surveilled and recorded. COVID symptoms were assessed by a self-report, and so of course we have no way of knowing if people were hesitant to report for any number of reasons. There's also a difference in efficacy between age groups that remains unexplained, with decreased symptomatic seroprevalence in individuals above 50 years of age from masking villages, but not for those below that age. This could be due to potential differences in group behavior, but we aren't sure. The results are encouraging, though, and provide some insight into the types of measures that may increase mask wearing and further confirmation that appropriate mask usage helps stem the spread of COVID-19. Given the number of lives we've lost to this pandemic so far, this information could be highly useful to public health efforts made to save lives. In addition, for everyone asking, where's the randomized controlled trial? Here it is. If you enjoyed this episode, you might enjoy this previous episode on obesity and weight loss drugs. We'd also appreciate it if you'd like and subscribe to the channel down below, and consider going to patreon.com/healthcaretriage, where you can help make the show even better during a global pandemic. We'd especially like to thank our research associates, James Glasgow, Edward Lilyaholm, and Joe Sevitz, and of course, our Surgeon Admiral Sam.